My name is Brendan Healy. I'm a consultant in microbiology and infectious diseases. And I'm talking today about the optimization of antibiotic therapy in critically ill patients. And I'd just like to say thank you to the Royal College of Pathologists for inviting me to give this talk. So the learning objectives that I was set was to understand the need for antibiotic therapy optimization in critically ill patients, and to understand how to optimize the pharmacokinetic and pharmacodynamic properties of antibiotics for treatment of infections, especially in the critically ill patient. So I'm going to talk about pharmacokinetics and pharmacodynamics, but I'm not going to spend the whole talk looking at that particular topic, because I think there was lots of other important issues in related to management of infections in the critically ill. So as an outline, at the beginning, I'll just talk a little bit to begin with about the types of infections that you see in the critically ill patients on the intensive care unit. I'm going to talk about antimicrobial stewardship, a bit about start, smart, then focus, talk about microbiology pitfalls, the things that we see when we're doing our ward rounds on ICU, things where clinicians, I think, sometimes get a bit confused in relation to microbiology. And then to finish up by talking about the pharmacokinetics and pharmacodynamics of antibiotics and how that can be challenging in the critically ill patient. So in relation to ICU related infections, they're 5 to 10 times higher than hospital associated infection rates on a general ward, and they occur at a rate around 40%. So it's a real issue for the ICU managing critically ill patients. Ventilator-associated pneumonia is the leading cause of death from hospital-associated infections, and the prevalence is about 50%. We know that mortality is higher if antimicrobial resistance is present. We also know that ITUs are a breeding ground for resistance. There's high antibiotic use, compromised patients, and then a shared environment. And the high antibiotic use creates a situation where through simple Darwinian principle, there's a selective advantage for resistant bacteria. Add into that the fact that we've then compromised the patient so that bacteria, some of them that wouldn't necessarily be causing significant problems for most patients, are able to cause infection in the ICU patients. And then you've got this shared environment, which means these bacteria can then move from the patient to the environment and potentially from patient to patient. And this graphic is really just to show the sorts of reasons why the intensive care patients are so compromised. Essentially, we compromise every single part of their immune system to make them at risk of infections. So we can see in this X-ray here, the patient is intubated. And when someone's intubated, we put a bit of plastic down through to their lungs. We've created essentially a motorway whereby bacteria can bypass the protective mechanisms of the nasal cilia, the nasal mucus, and gain access to the lungs. So bacteria that might not otherwise routinely be able to get access to the lungs can get in very easily. And in addition, whenever we try and treat these patients, we might be able to clear some of the infection in the lung itself, but we're never really going to be able to clear the infection that's sitting on the plastic. There's likely to be biofilm. And so there will also always be a possibility for bacteria to re-enter into the lung. And that's really why I'm going to spend some time talking about infection control and antimicrobial stewardship, because each time we treat a patient with antibiotics, we might clear some bacteria from this setting, and that's likely then to be replaced with more resistant bacteria. And so I think sometimes when we talk about antimicrobial stewardship, we think about it in a global sense, but actually there's real reasons in these patients why the detriment can be to them in the long term. And that's why we have to focus on giving the narrowest possible spectrum agents and to only use antibiotics when we absolutely have to. Again, demonstrated on this X-ray, we have a central line, so we've bypassed the patient's skin. There's another portal of entry. Patients will often be catheterized, another portal of entry. Sinusitis is something which can be quite common in the ITU setting and easily overlooked. Patients will often have wounds, bed sores, surgical wounds. They can often be cachectic, increasing their chance of having bed sores and other wounds, another source of infection. So in essence, patient heavily compromised, lots of antibiotics potentially, colonize them with more resistant bacteria, and it's a vicious circle for those patients in the ITU. Finally, just to mention, of course, there are other prostheses used, intracranial drains, chest drains, etc. And then I'm sure, like us, you're seeing increasing resistance in bacteria, and this creates a problem for us in terms of managing patients in this setting. We see quite frequently now carbapenems producing organisms. We're probably seeing 1 or 2 a month in our hospitals. This is very similar to when I started as a registrar with ESBL type organisms. They weren't a major problem at the time. We were seeing maybe 1 or 2 a month. And I think within 5 years, ESBLs had risen exponentially to about 30% of the infections and really compromised what we were able to use, such that we had to use meropenem and tazocin much more frequently than we had when I first started. So this 1 or 2 a month issue is something which is really concerning to me, and managing these multi-drug resistant organisms is going to become commonplace. And then the Pseudomonas aeruginosa problem is something that we see even more frequently. In the ITU setting, we have resistant Pseudomonas aeruginosa commonly. As you know, it can develop resistance seemingly quite rapidly after antibiotic exposure, but we also get spread probably from patient to patient, or patient to the environment, and then the environment to patient. And this is another significant concern. And you can see here, I've given 2 examples of bacteria where we don't really have a good treatment option. I'm just going to leave that slide there. It's just the different types of ways that bacteria can develop resistance. You're probably aware that Pseudomonas develops resistance to carbapenems by altering its porin channel, so changing the ability of the meropenem, the carbapenem, to get into the bacteria. And that's why it develops resistance so readily to those agents. But you also have inactivating enzymes, altered target sites, and sometimes pumps which can push antibiotics out. And the Pseudomonads seem to have a number of different ways of overcoming antibiotic assaults. And then looking forward, of course, and again, something that we're seeing and using more commonly now are these antibiotics designed to overcome resistance. And all I'd say about these antibiotics is that they are, to a certain extent, repurposed antibiotics that are already in use. So the longevity of these antibiotics is likely to be short, in my opinion. We were fortunate when we had ESBLs that we had a completely new class of antibiotic to go to in the form of carbapenems, imipenem, and meropenem. But when you're just trying to extend the use of what's already available, bacteria will develop resistance to these combinations quite quickly, I believe. So we really are desperately in need of a new form of antibiotic therapy for these organisms, in my opinion. And the other thing just to mention about these drugs is, of course, when we come onto the pharmacodynamics, it can be quite relevant for these repurposed combinations, because sometimes they're working right at the edge of their effectiveness in terms of their the MIC and the target concentrations you can achieve. And for that reason, continuous infusion or long infusions are more relevant in this setting. Okay, so let's talk a little bit about antimicrobial stewardship and why am I, just to remind you why I am talking about antimicrobial stewardship. And it's principally because, in my opinion, antimicrobial stewardship in the ITU is as relevant for the individual as it is for the wider population. If you give antibiotics to a critically ill patient, you will promote resistant bacteria within that individual. They are in a setting where they could readily acquire such resistant organisms. And so anything we can do to reduce unnecessary use is really important. As I mentioned, if we use narrow spectrum agents when appropriate, we're pushing towards resistance less quickly, hopefully preserving the more broad spectrum antibiotics for a later date when we really need it. And you're probably aware of the mantra of start smart and then focus when it comes to critically ill patients. But this is a mantra, in my opinion, which has failed to a large extent. And the reason it's failed is because I think there's another mantra in medicine, which is, if it isn't broke, don't fix it. And the problem is, with the start smart then focus, starting smart often means starting with a very broad spectrum agent, so maybe tazocin or meropenem. And then by the time you get your microbiology results, where you're able to potentially focus, often you're into the mindset of, the patient's getting better, so they're not broke, so let's not fix it, let's just carry on with the tazocin and meropenem. So really, one of the things that we do on ITU, which is critical, I think, is look very carefully at the focus element of start smart and then focus. And we encourage our clinical staff to focus based on the cultural results available. And that is imperative in this start smart and then focus mantra. I'll talk a little bit about understanding microbiology and the need not to overinterpret it. We do ward rounds on our critical care unit 3 times a week, and I'd like to think that our colleagues in ICU are well educated when it comes to microbiology. But I would say that there's still a pressure, really, if you have a microbiology result, of a feeling like you have to act on it. Now, from my perspective, it doesn't matter what sample you take, pretty much. There's a few exceptions, such as blood cultures and CSF. But every other sample that you take, we will grow something from it. So if a patient is ventilated, we will always grow something from their lungs. We'll always grow something from sputum. We'll always grow something from skin. We'll pretty much always grow something from urine, especially if the patient's catheterized. Sorry, I should say, if the patient's catheterized, we'll always grow something from the urine. And what that means is, just because you've got growth, that doesn't tell you that there's an infection present. So you have to be really careful about interpreting microbiology. I'd encourage you not to send specimens unless there's a good reason to do so, and then be very cautious in your interpretation of results. And then, as well as antimicrobial stewardship, if we really want to prevent infections in these patients, we have to prevent spread from one patient to another. And that means really strict adherence to infection prevention and control procedures, hand washing, use of aprons, and environmental cleaning to try and reduce transmission from the environment to the patient. So in terms of reducing unnecessary use, one of the first parts of that is the appropriate clinical assessment. And these are the sorts of things that we look at when we do our ward rounds on the ITU. So we're always interested in the history, of course. In the ITU setting, history is often limited or not available once the patient has been intubated and ventilated. And that means you're relying more on other features, such as the examination. And then we look at their parameters, the temperature, noradrenaline requirement, oxygen requirement, blood pressure, saturations, and heart rate. We look at the blood results. We do use white count, CRP, and procalcitonin, not necessarily to look at one-off measurements, but to look at trends, to follow, to see if CRP is climbing or procalcitonin is climbing, and then also in response to antibiotics, whether it's falling or not. Imaging results, chest x-ray, CT, and then we put that together with the microbiology results, non-directed bronchial lavage, which is where we just put a catheter into the lungs and sample from there, sputum, urine, blood, etc. And like I say, not to overinterpret it, and always put it together with the clinical picture. So then there are some pitfalls, I would say, in infection management that we come across. Failure in the history. So when we go to ITU, we're very reliant on our colleagues giving us the history and the examination findings. And so if they're wrong, essentially you're looking at a sort of rubbish in, rubbish out scenario. So it's very important that we get the right information on the patient, and that the patient is very carefully assessed when it comes to deciding on infection management. I think there's a general overuse of antibiotic. We often say that there's no such thing as tazocin deficiency. Tazocin is the favored antibiotic of most clinicians in our health ward at the moment. So we're really always encouraging the judicious use of antibiotics. I'm going to talk about chest x-ray findings in a minute, so I'll come back to that. Missed opportunity for blood cultures. This is a big problem for us from time to time. So people often in the UK will only take a blood culture if the temperature is over 38. But I really want to see a blood culture taken if the patient is deteriorating, is thought to be from an infection perspective, and there's going to be a change in antibiotic management. One of the first things we do when we get called about a critically ill patient is look at their past microbiology results. Now, the reason for doing that is we get an understanding by doing that of the sorts of organisms that the patient is colonized with. Sometimes you'll find someone's colonized with a very resistant organism, and if you hadn't looked at the past microbiology results, then you might start an antibiotic which isn't appropriate for that individual. I'm going to talk a little bit later about penicillin allergy, and I've already highlighted what I consider to be one of the most important topics in all infection management, really, which is infection control, adherence to infection control policy, all around hand hygiene, environmental cleaning, use of single-use items, and not spreading organisms from one patient to another, or reducing the risk of that. So what about antibiotic use? So first and foremost, we should only be using antibiotics where there is an indication. But there's another part of the assessment that I don't think we talk enough about. And I think it's a really important aspect of antibiotic management, because if we want to limit antibiotic use or reduce unnecessary use, we have to be comfortable with when we're not going to start antibiotics. And for me, some of that assessment is looking at the patient and asking yourself, have we got time to wait? So there might be some signs of infection. Maybe there's a fever, maybe there's a white count gone up a bit, maybe the CRP's gone up a bit. But I want more than that. I want to see, you know, is this patient's trajectory one where we really need to start antibiotics now, and there's no time to just see how things evolve? Because it's worth bearing in mind that some infections will just be self-limiting. And the other question I ask myself is, have I got time to get it wrong? Now, I'm not suggesting at any stage that I want to get it wrong, but in some settings, you might want to go with a narrow spectrum agent. You think it's a respiratory tract infection, let's say, and you want to use narrow spectrum. And that can be appropriate, particularly if the patient is reasonably stable. In other settings, the patient may be really sick, and under those circumstances, you might say, well, okay, look, we haven't got any time to get it wrong, so we're just going to have to go very broad, very early, and then focus at a later date. We always want to get samples from microbiology before starting antimicrobials. There shouldn't be any delay in collecting them in the critically ill setting. So a non-directed bronchial lavage, sputum, whatever your choice of sampling is, blood cultures, urine when appropriate, feces when appropriate, etc. again, just to highlight the importance of checking previous microbiology results before prescribing antibiotics. Yes, another thing we get asked about quite often is around starting someone on therapy who's already received antibiotics previously. And the first thing I do when I'm asked that question is I try to assess whether this is recrudescence or treatment failure. So the typical pattern for someone who's recrudescing is they were on an antibiotic, it was stopped maybe 48 to 72 hours ago because they were doing well, and now they're starting to get signs of infection again. And in that setting, for me, the decision on what to do is relatively easy because you just put them back on what was working before. Treatment failure, on the other hand, is where someone was on an antibiotic and they weren't really responding, or they're still on an antibiotic when they're starting to get worse. And in that setting, then you have to escalate the antibiotic treatment. We always encourage a treatment duration, a stop date and an indication. And the reason for that is quite simple. If you don't put a treatment duration, a stop date and an indication, then people can end up on antibiotics almost indefinitely. And these are a really important aspect of antimicrobial stewardship. Unfortunately, in my opinion, by creating a treatment duration, we, to a certain extent, have created this idea that there is somehow a magic number when it comes to infection, that, you know, if you give 5 days, for example, for a respiratory tract infection, then that is the magic number. Whereas in reality, it's more complicated than that. So one patient with a very severe respiratory tract infection may need longer than 5 days, and others might need shorter. And we you know, there are studies which show that 3 days can be enough in certain settings. And then we encourage a review of antibiotic use daily, because you need to be making a decision. Has the patient had enough? Is it working? Do we need to escalate? Do we need to stop, etc.? So some things that I think we see from a microbiology misunderstanding perspective. So I think one of the biggest things is that people think tests are diagnostically useful. For me, tests and microbiology tests are mostly useful in guiding therapy, but they don't generally tell you whether an infection is present or not. And we've covered this already. So just remember that in general, we are not sterile beings. We're covered in bacteria. If I swabbed myself, if I sent in a sputum now, I would expect to grow something, and if I looked hard enough, you know, would definitely grow something, or something relevant potentially. But I'm well and I don't need antibiotics, and we have to approach patients in the ITU in the same way. I think there's a general feeling that antibiotics are safe, and so it's not uncommon to come across people who give antibiotics just in case, and we need to be stronger than that in terms of limiting antibiotic use. And I'll say it again, it's not just for the wider population, that's for the individual as well. Sometimes I think people think that we have some sort of hotline to the bacteria, and that the bacteria are going to tell us what they're up to in the patient. But actually, we're really reliant on what we're told. So we need clear history, clear examination. And if you put rubbish in, you'll get rubbish out. This isn't related to critical care, but it does just show the frailty of the chest X-ray. This is from an audit I did on our admission unit some time ago. And we were able to match the chest X-ray interpretation of the clinician with the chest X-ray interpretation of the radiologist in 26 cases. And there was a mismatch between what the clinician thought and what the radiologist thought in 13 cases. Which essentially meant you had a 50-50 chance of having the same interpretation of the chest X-ray. So in 5 cases, the clinician thought there was no evidence of infection, but the official report said there was. In 4 cases, the clinician thought there was an infection and the official report said there wasn't. There were some other mismatches. And what I'm trying to highlight here is we have to be very careful about interpretation of imaging, and chest X-rays are probably one of the hardest things to interpret. And a reminder again to treat the patient, treat the patient, treat the patient. And what I mean by that is we don't use a single parameter. We don't use the microbiology result. We don't use the CRP. We don't use the white count. We don't use the chest x-ray. Nothing is used in isolation. It all has to be put together into a coherent story. We need to know how to assess someone who is not improving on antibiotics. And there are a number of causes of antibiotic failure. I think the first thing that comes to mind when antibiotics are not working is antimicrobial resistance. But we have to consider alternative causes of antibiotic failure. So, are you giving the right dose? Is the antibiotic appropriate for the infection that you're trying to treat? So just bear in mind that when you give an antibiotic, you give it intravenously, it then gets to the site of infection via the blood supply. And some antibiotics get into some areas better than others. Lack of source control is something which is really important in the critically ill setting. So again, antibiotics will work well with limited infection. They'll get into tissue and sort of mop up small amounts of infection in most sites. However, if there's no blood supply to the area, so if there's an abscess or necrotic tissue, then the antibiotic won't even get into that area. So you're going to need surgery to treat that. Same thing for metalwork, no blood supply, no antibiotic, you're going to need surgery. Biofilm, antibiotics don't penetrate very well, surgery likely required. So source control is a key element of infection management. Always think about drug fever. We see drug fever pretty commonly, particularly with beta-lactam agents. I'll always ask what the eosinophil count is in that setting. If it's raised, it pushes me towards, could this be a drug fever? But worth bearing in mind that some people will get drug fever without an eosinophilia. You have to think about other causes of fever. And then, of course, you do have to think about antimicrobial resistance. And that's where you get samples and look at previous microbiology. So just to go back again, so we talk of, there are lots of good reasons to give antimicrobials. They're effective, they reduce mortality, but we have to think a bit about why not to give antimicrobials. And I've covered this already, so I'm not going to dwell on it. But you have to think about the selective advantage it creates for resistant bacteria across the whole unit, but also in the individual. And we have to bear in mind that what is good for society is also good for the individual. So if antimicrobial stewardship is generally good, it will also benefit the individual. But as I've already highlighted, there's lots of reasons in this particular setting why avoiding unnecessary antimicrobial use has a very important impact on that individual during that immediate stay. We want to try and avoid emergence of resistance. We know that there are adverse effects. And one big adverse effect that we see in our country is C. diff-associated diarrhea. Okay, so talk a bit about the microbiology and susceptibility testing, because we're starting to get now into the pharmacokinetics and pharmacodynamics. So one of the first things we do is in determining the sensitive or resistant, whether an organism is sensitive to resistant to an antibiotic. Technically, we want to try and get the minimum inhibitory concentration, or the MIC. So in order to determine the MIC, you put a known amount of the bacteria into a test tube with a different concentration of the antibiotic, and then you look to see where the bacteria stop growing. So in this graphic, green is where the bacteria is growing and yellow where it's not growing. In real life, it sort of goes cloudy. It's clear and cloudy. So this would be clear and that would be cloudy. So in this particular example, the minimum inhibitory concentration, the concentration required to inhibit growth of this bacteria, is 0.5. So that's the gold standard, if you like, of sensitivity testing. We rarely perform this type of MIC anymore. Mostly we would do something called an E-test, and these are E-tests here. For example, on this one, the E-test is reading at 0.004. So this is the way we do minimum inhibitory concentration, mostly in the lab now. It's also worth bearing in mind, and you have to find out from your own lab what testing they're doing, but it's not uncommon for us to do antibiotic testing using these discs. And then with these discs, you have a zone size, and the zone size will determine whether something is sensitive or resistant. And that sensitive or resistant is roughly equivalent to the MIC. But the other thing that's worth bearing in mind is that you get a report which says a bacteria is either sensitive or resistant, but you should think a little bit about what that actually means. So let's imagine that the cutoff for resistance is 0.5, for example, in this example. So this organism here is sensitive because the MIC is 0.5, but actually it's sensitive right around the cutoff. And if you repeated this MIC 10 or 20 times, sometimes you might get 0.5, sometimes you might get 0.25, and sometimes you might get 1, because there's such a single dilution difference. Now, if the organism tested sensitive at 0.006, then obviously it's still going to be reported as sensitive, but it's considerably more sensitive than this organism that's demonstrated here. So it's worth bearing in mind that sensitive and resistant, they seem like dichotomous variables, but they're not. It's more complicated than that. It's a spectrum, and you might have some organisms which test resistant, but actually respond as if they're sensitive. And you'll get other organisms that test sensitive, but they're on the borderline. And if you can't get high enough concentrations of antibiotics, they may not respond. Obviously, the cutoffs for sensitive and resistant are set so that in the most part, if it tests sensitive, it will respond, and if it tests resistant, it won't respond. But just bear in mind that it is a continuum. Okay, so we know what the MIC is, and then we have to look at the pharmacodynamic parameters. So when you give an antibiotic as a bolus, there are various parameters that you get. So the Cmax, that's the maximum concentration of the antibiotic after you've given your bolus injection. This graph here shows the area under the curve. And this box here is the time where the antibiotic concentration is greater than the MIC. And there are different antibiotics which have different pharmacodynamic parameters that determine their efficacy. So for aminoglycosides, aminoglycosides have concentration dependent killing, and they have a long post-antibiotic effect. So for aminoglycosides, the critical parameter is the Cmax over the MIC. And that's why for aminoglycosides, we're really looking to try and get a high concentration. So we give a bolus and we get a high concentration, and then we have a long interval before we give the next dose of the aminoglycoside. And then there's another reason for that, and that is because if we have a long interval, then there's a period where there is no aminoglycoside in the system, and that reduces the toxicity of these agents. For most antibiotics, or for a significant proportion of antibiotics that we use, bearing in mind that a lot of them are beta-lactams, or also the glycopeptides, vancomycin and teicoplanin, the critical parameter is time over MIC. Now, one of the interesting things about time over MIC is that giving bolus or intermittent infusions of antibiotics is not the best way of achieving time over MIC. So you'll see here, you give the antibiotic, you overshoot, so you're giving more than you need to, and then there's a period where the amount of antibiotic present is below the MIC, and if you like, that's wasted time. The duration that you have to be over the MIC is around about 40%. So even though this isn't necessarily the optimal way of giving the antibiotic, it is still effective. Otherwise, as you know, we probably wouldn't be giving it that way. But actually, if you give a continuous infusion, you could flatten out this curve. You could increase the time over MIC, reducing the potential toxicity related to high dosing, and also reducing the risk of being below the cutoff of the MIC. We've also got the area under the curve as another parameter. And it's worth bearing in mind that all these parameters are linked. So if you have a very high Cmax, you're going to have a higher area under the curve and a greater time over the MIC. So they're all linked, but different parameters map better with certain antibiotics. And for quinolones, it's the area under the curve, which is the important parameter. So what about when you're on the ward and you're trying to decide which antibiotic to choose? So the way that we choose an antibiotic is we first of all determine the site of infection. So that's why the history and the examination is critical, because we need to know the area that we think the infection's in. If we know where the infection is, we can then predict the likely infectious causes. So in the setting of a respiratory tract infection, if it's from the community, we know it's likely to be Streptococcus pneumonia, Haemophilus influenza, etc. Or if it's a ventilator-associated pneumonia, we know it's likely to be gram-negative bacteria, maybe Pseudomonas, those sorts of things. And when we know what the likely infectious cause is, we then have the choice of antibiotics. So we'll map the antibiotic against the likely organisms. Often on the clinical side, the middle section, the likely infectious cause, is missing in the clinician's armamentarium. What the way we often think on the wards is, right, where's the site of infection? And then we go to our antibiotic guide, if you like, and say, right, that's the choice of antibiotic. And it's important to understand that it's a three-step process, because sometimes when things are not going well, so if you know the site of infection, you go for the choice of antibiotic, but the patient's not getting better. The way that we try to unpick this is we go back to the likely infectious causes, and then we start to try and work out, right, why might this antibiotic not be working in this particular setting? So just encourage you to understand that as a process without necessarily going into the detail around it. But the other thing that we've got a privilege in microbiology is because we're sending out reports all the time, we have a really good understanding of the likely infectious causes in any unit. So in our hospital, we have a burns intensive care unit, we have a cardiac intensive care unit, and we have a general intensive care unit. And the types of pathogens present in those three units are different, but we have a good understanding of what you're likely to get in each of those units because we're reporting microbiology results on them all of the time. Other factors, now I'm just going to run through these slides. I'm not going to go into them in too much detail, but all I'm trying to show here is that, again, often when we're thinking about what antibiotic to use, we simplify it to site of infection, choice of antibiotic, give the right dose. But actually, it's much more complicated than that. And most of the time, we don't have to get into the detail of why it's more complicated. But when things aren't going well, it's useful to understand all these factors, because you can then try to unpick it and try and work out why things aren't working. So, you know, there's the factors like how the antibiotic works. Is it bactericidal or bacteriostatic? How are they absorbed? Where do they get to in the body? You know, do they get to all the infectious sites that we're worried about in this individual? How's the body get rid of them? Are they metabolized or renally cleared? What are the common side effects? What about resistance? Is it common? Could it have developed? Might the organism have some resistance that wasn't picked up on initial testing? And you can get a lot of this information about the pharmacokinetic properties by just putting in the SPC. So in this example, I've put tazocin SPC as a search. Then I've brought up the SPC, which in this case is the EMC. And I've got information about its absorption, its distribution, its elimination. And I can use that in a situation where it's not working to try and unpick what might be going wrong. I think we've covered all of that. So you can break it down in another way. You can think about the infection-related factors. So where's the site of infection? Is there any toxin-mediated disease? What are the likely resistant mechanisms in the organisms that cause infection at that site? Again, the site of infection, the likely pathogen, the approximate duration, the choice of antibiotic. You look at patient-related factors around allergy, age, organ failure, immune response, etc. And then you've got the antimicrobial factors, the pharmacokinetics, absorption, distribution, metabolism, etc. And then when we're picking the antibiotic, we need it to be effective against the likely organisms. We need to think about sensitivity or resistance. We need to think about the absorption and the route, distribution to the site of infection, excretion, side effects, and toxicity. I'm just going to leave this slide in there that you can look at your leisure. I'm not going to go through it, but there are different mechanisms of action of the antibiotics, which are demonstrated neatly here in this infographic. Okay, so now I'm just going to talk a little bit about optimization of dosing, which is something that's, I suppose, gained prominence in the last few years. Some people are real advocates of this PK/PD parameter use, particularly in the critically ill patient, where the situation can be quite confusing and quite difficult to manage. And it's difficult to manage for a number of reasons. So we've talked a little bit already about the pharmacokinetic and the pharmacodynamic parameters. So we know that for Betalactams, it's time over MIC. We know for aminoglycosides, it's Cmax, and for Quinolones, it's area under the curve. Now, in the critically ill patients, there's all sorts of reasons why the dosing that we might normally use could be inappropriate. So the first thing is the volume of distribution, and that can be increased in the critically ill. So that means you might need a higher dose or a higher loading dose in order to get to all the to fill the volume, if you like, of that individual. We then got the issue of protein binding, and in the critically ill patient, their albumin and protein is often low, and that can change the volume of distribution as well, and it can have an effect on clearance because you might have more free drug than you would have in a healthy individual. And it's worth bearing in mind that a lot of pharmacokinetic studies are done on healthy individuals, or certainly not in the critically ill. You've then got to think about clearance, and interestingly, patients can have an acute kidney injury. Of course, we know that. We've got ways of measuring that. Our ways of measuring it are not perfect, and they can underestimate the level of kidney injury in many settings. But you've also got this situation of augmented renal clearance. So in the critically ill, sometimes getting rid of the antibiotic renal clearance of any description can be happening in an augmented fashion. So you've sort of got a suprarenal function, and that has a direct effect on the antibiotic clearance as well. And we don't have a good way of measuring that, and we can underestimate renal clearance quite significantly with the tools that we use, which are often based around creatinine. Around creatinine. I put there, so we'd need to know what the target MIC is. Now, sometimes we might have an organism, we might have grown an organism. We'll rarely know what the MIC is. We'll probably only know if it's sensitive or resistant. It may be different in Ghana, but in the UK, we will rarely have the MIC. So more often than not, we're dealing with a theoretical organism, and the best we can do is aim for the MIC at which the antibiotic is effective, but not based on the organism that we're specifically trying to treat. We've got to think about toxicity, and we've got to think about therapeutic drug monitoring. Now, so let's imagine that we could do therapeutic drug monitoring of any antibiotic at any time whenever we wanted to. And so we've got at our fingertips the plasma concentration of the antibiotic. But then we have to ask ourselves, does plasma concentration equal the concentration of the antibiotic at the site of infection? And actually the answer to that is not necessarily. So for example, in the fluid in the lung, you get impaired penetration of aminoglycosides and beta-lactams. So even if you had plasma concentration at your fingertips, it may not match with the concentration of the antibiotic at the site of infection. I've put at the bottom there an article that you can go to. It sets out optimization of dosing quite nicely. It's quite easy to read, and I'd encourage you to have a look at that. However, I've put all this down, and it's all very interesting, but what does it mean in reality? Well, in the UK, we rarely optimize dosing in the critically ill in the way that the papers discuss it. And why is that? Well, the real reason is we don't have therapeutic drug monitoring for most of the antibiotics. So we're lacking that piece of information. We don't have a good way of measuring augmented renal clearance. So we know it's a thing, but we don't know if it's happening in this patient or that patient. We don't have any better way of managing acute kidney injury than the EGFR. So again, we know it's happening, but we're not able to specifically measure it in that individual patient. The volume of distribution, we're not able to measure. The target MIC we don't have available. And what that means really is that we're left dosing people in, if you like, a normal way, although it wouldn't be uncommon for us to give higher doses of many antibiotics in order to cover this complicated factor around the critically ill, whereby we know that optimization of dosing can be difficult. A couple of things to just go through the different antibiotics, so how they work and how you might optimize dosing. So beta-lactams, generally we think of them as having good penetration, wide distribution, so they get to most sites of infection. They're bactericidal, they destroy the cell wall, and they're relatively non-toxic, so it's relatively easy to increase the doses or use maximum doses in this setting. So for meropenem, it wouldn't be uncommon for us to use 2 grams 3 times a day, flucloxacillin 2 grams 4 times a day, etc., etc. There is the issue of penicillin allergy, which I'll touch on briefly. It's worth knowing, I'm not going to talk to this slide other than to say that there are lots of different types of beta-lactam antibiotic just listed here. Glycopeptides, unlike beta-lactams, are large molecules, so generally they have poor penetration. In general, they're inferior to beta-lactams where the organism is sensitive to a beta-lactam. They also have a narrow therapeutic index, and the one setting actually where we use optimized dosing, or sorry, not optimized dosing, continuous infusion, is in the glycopeptide, and that's really to do with the fact that the toxicity is an issue. So by using continuous infusion, we're able to optimize our dosing of these particular antibiotics. Quinolones have very good penetration, a very wide distribution. They're very good because they're oral, and they're the only oral agent available for Pseudomonas. And as such, we try to preserve them because I like to try and keep that as an available option for when the patient might get discharged, for example. Resistance is a problem for quinolones for us. It's gone up to around 30%. So they really have to be used sensibly, and they're a big issue in terms of C. diff. Now, finally, I was just going to touch on penicillin allergy because I don't know what it's like in Ghana, but in the UK, patients are often labeled as penicillin allergic when they aren't. And if you're labeled as penicillin allergic, you're immediately reducing the number of antibiotics that are available for use quite significantly. And so it's a really big factor, and we're really keen actually to try and make sure that patients are only labeled allergic when they actually are. And there's also the issue around types of allergy and whether there's cross allergy with other and other related beta-lactams. And really what we're talking about there is whether someone has a type 1 allergy. And these are the factors that point towards a type 1 allergy. Is the onset within the first 72 hours, any urticaria, itchy rash at any time, laryngeal edema, bronchospasm, hypertension. And if these features aren't present, then in general, you're more confident using a different type of beta-lactam. So if, for example, the patient was penicillin allergic, you might be comfortable using ceftriaxone. And then commonly in our hospital, if firstly, we try and get rid of the allergy history altogether where it's appropriate. And if that's not possible, then we'll often use meropenem, because the cross-reactivity between penicillin and carbapenems is low in general. Okay, so that's my talk around optimization of antibiotics in the critically ill. I'm going to finish just by sharing a couple of quotes around antimicrobial stewardship. You can see, I suppose, how passionate I am about antimicrobial stewardship and the importance to use antibiotics only when absolutely indicated. And that is because, in my opinion, it's not just good for the critically ill society, but also good for the individual in this setting. And this is a great quote from Brad Spellberg, that antibiotics are among the most potent of all anxiolytics for prescribers. And I think we're all guilty of that from time to time, where we think, where we are anxious about not giving an antibiotic, and therefore we reach for the antibiotic. And we really have to try and manage our own anxiety at times, because we have to think about the consequences of unnecessary use of antibiotics. And this second quote, also from Brad, I believe, is to learn how to use antibiotics, we must first learn how not to use antibiotics. And just to take you back to that part of the talk where I mentioned about trying to assess more than just whether we think there's an infection present, but also assess, is this patient got an infection where we need to start antibiotics immediately, or have we got time to assess, and whether we need to go in with broad spectrum or whether we've got time to go in with a more narrow spectrum agent first. And one of the massive changes in my career has been around management of community associated pneumonia. Obviously we know that amoxicillin will work frequently in community associated pneumonia, but our general practice in ITU would be that if they were so sick that they were coming to ITU, we would start them on a more broad spectrum antibiotic. This whole start smart then focus idea. We rarely get to pathogen in community acquired pneumonia. So lots of these patients would come in, they'd get started on a broad spectrum antibiotics, and they'd stay on those broad spectrum antibiotics for the duration of their stay. More recently, in the last 5 years, probably, we've gone back to using narrow spectrum agents. And it's incredible how frequently someone comes in with a community acquired pneumonia, they're treated with amoxicillin and clarithromycin, and they respond beautifully. And we've saved a huge amount of unnecessary broad spectrum antibiotic use by that change. And we did probably a reasonable amount of harm by going in too broad too early with those patients for a long period of time prior to that. So that's the end of my talk. Thank you again to the Royal College of Pathologists for asking me or inviting me to give this talk. I hope it's been beneficial, and I wish you all the best in looking after your patients. It can be a very difficult journey looking after patients, both emotionally and intellectually, and I'm sure you all do a great job, and I wish you all the best. Thank you.